Hello everyone, my name is Dr. Madhadar and you're watching sqadia.com. Today our topic is the knee injuries. As you know, if you see the anatomy of the knee joint, this is a lateral view which has been shown on the screen. If you can appreciate, this is the femur bone on the top. You have a capsule, this is the posterior articular capsule. This is the cruciate ligaments, this is the PCL, this is the ACL, and from as we can view it from the lateral side, this is the lateral meniscus. This is tibia, and then we have patella in front. There's a quadriceps tendon is coming down. It's actually attaching on the superior as well as the two lateral surfaces of the patella. Then it becomes one single patella tendon and attaches on the tibial tuberosity. As the quadriceps tendon is coming down, there is a bursa between the quadriceps tendon and femur, which is called as prepatellar bursa or suprapatellar bursa, and then there is patella. With prepatellar bursa is just below where the quadriceps tendon is actually crossing the patella and getting inserted onto the tibial tuberosity as well. And then there is a synovial cavity, which is actually the joint inside the joint cavity, which can be appreciated on this diagram. Infrapatellar bursa exists just below the patella, and this is due to because the patellar tendon will rub against the tibia, which will lead to bursitis and problems of the tendinitis as well. So it is whenever a tendon passes across the bone, there is actually the bursa, different bursa which are present to prevent the friction which can occur when the tendon moves or glides past the bone. So you know there are two meniscus. There is a lateral meniscus and the medial meniscus. Lateral meniscus is present on the lateral tibial condyle, while the medial meniscus present the medial tibial condyle. If this is the tibial tuberosity, usually the lateral meniscus is more of a horseshoe shape. Although they both can be classified as C shape, but it's more of a horseshoe shape, while medial meniscus is morely C shape or more conformity with a C shape meniscus. They're attached by there's an anterior horn of the both meniscus, then they're attached to the tibia by anterior and posterior horns. Usually the most commonly injured in isolation, the most common injured mechanism meniscus is actually the medial meniscus. If in knee injuries, especially in the case of adults, if there is isolated meniscal injury, that is associated with medial meniscus, but lateral meniscus has increased chances of being injured with the ACL, and there is most commonly as when the ACL ruptures, this is always mostly associated with the lateral meniscus injury as well, and there's always some degree of external rotation, and due to that happens. If a patient restores or a patient suffers from a meniscal injury, what are usually the sign? The one most commonly sign is actually the pain, especially during walking. There may be mild swelling, maybe massive swelling of the knee as well if it is associated with the ACL and lateral meniscus, both are involved. There is usually catching or clicking sound which can be appreciated as well, because that is when there may be the steer gets stuck in. There is always during certain phases of the gait, there is always catching and clicking or locking of the knee joint. This is usually the patient comes and complains with this kind of a history, and when you examine it, the patient is usually there's a McMurray test which actually tells you whether there's medial meniscus involved or the lateral meniscus is involved. And for the most common area involved is always the joint line tenderness. If it's the medial meniscus, it's always the medial joint line tenderness. If the lateral meniscus, it's always the lateral joint tenderness which comes in. Now, as you can appreciate it over, the meniscus may be torn in any fashion. There could be paradopic tears, there could be radial tears, there could be vertical tears, intersubstance tears, red zone, red-white zone, or white zone tears as well. Usually, these meniscus are declassified in differently depending either which zone is involved or which geometrical lesion it is. That is how we classify the meniscal tear usually. This is a normal meniscus. This could be a vertical tear or a radial tear as well, which is along the radial line radius of the meniscus. There could be a bucket handle tear in which involves a kind of a flap is actually lifted off the surface with both the anterior and posterior horn are intact, leading to this kind of a bucket handle tear. There could be a transverse tear as well. Then there are other tears as well which involve, could be a parent peak tear or maybe other types of tear as well. This is one way of classifying meniscal tear, is a geometrical lesion, that how geometrically you can classify that kind of a tear which is present in the meniscus. The other way is actually the meniscus in which zone is it involving. If this is the meniscus, it's actually divided into 3 zones. There is the outer 1/3 zone which is called as the red zone, because the peripheral blood supply is coming from the outside by middle geniculate artery. Then there is inner zone, which is middle 1/3, which is actually called as red-white zone. And then there is inner 1/3 zone, which is termed as white zone. This white zone is actually usually avascular. There is decreased vascular supply of red-white zone, and the only zone which is richly vascular is actually the red zone. So if it's tear of red zone, that means that there is vascular supply over there. Probably the repair would be better for the patient, because meniscus have a role in the knee. The most important role is actually to distribute the forces which are actually during the axial loading of the body when the patient is standing or patient is walking around. That is actually the distribution of load properly over the whole surface, and if that is why, then repair is a good option. But if it is red-white zone, the repair may fail actually, and usually the repair is almost always fails in the white zone. So it is important to know which zone it is and whether repair can be done or not, and then we may have to go for partial or complete meniscectomy as well. Our other type is called as degenerative tear. These are usually occur in older individuals above the age of 40, and that is because over the years the meniscus have degenerated, maybe due to osteophytes, which as osteoarthritis develops in the knee. There may be osteophytes which may be rubbing against the surface, leading to degenerative type tears of the medial or lateral meniscus. Now this is, if you see it over here, this is where the meniscus axis can be actually seen. Usually it's classically called as the bow tie appearance. This is actually, it appears like a bow tie on a sagittal view of an MRI. And what is important is that you have to understand, if there is a white line in between or involving the substance, this could be a tear of the medial or lateral meniscus. Depending upon this, is most likely the lateral meniscus sagittal view, because you can appreciate fibula over here and more convex surface of the lateral tibial condyle. Now this, if you see this bow tie seems to be disrupted. Why? Because there is actually edema, there is something wrong over here, as well as there's some tear as well. Now this could be a radial tear, or it could be intersubstance tear of the lateral meniscus. If you see over here, you cannot appreciate the other end of the bow tie. This means there is something wrong over the lateral meniscus, or it has either degenerated, or there's actually a radial tear, or maybe a buccal tear of the lateral meniscus. Now coming to the treatment. Treatment usually of the degenerative meniscal tear, these occurs in the patients more than 40 years of age. The most important treatment is exercise therapy. You have to give them analgesics so that the pain is there. Then the aggressive physiotherapy, actually the muscles take up the more weight of the alignment, and therefore the ligaments have to be their workload of the ligaments actually lessened. And then maybe the ideal treatment for arthroscopy is go for an arthroscopy, and usually requires partial or complete meniscectomy. But then it depends. If it's rarely, although it happens, but usually if the degenerative tear is involved mainly the white zone or white zone, but if it is involving red-white zone or red zone, then repair can also be an option. If it's a traumatic meniscal tear, which is usually common in younger age group, especially if, for example, with high energy trauma or with sports injuries, when there's the ACL rupture, there may be an associated LCA, lateral meniscus rupture as well. If initial treatment is always the same, that you have to, as per guidelines, that you have to assess the whole thing. You have to go for reconstruction of ACL, whether it's the associated lateral or medial collateral ligament injury or not, then that may require repair as well. And then depending upon which zone is it, then along with that we can go for either repair partial or a complete meniscectomy of this tear, or which has actually gone a traumatic tear. So it depends which type of tear it is and whether which zone it is involving. We can go for partial meniscectomy, complete meniscectomy, or even repair of the meniscal injury as well. Now followed up by excessive physiotherapy and exercise program, so that the muscle can be strengthened over the long period of time and the knee kinematics can be restored. This now coming to the osteochondral injury or osteochondritis dissecans. Osteochondral, as the name suggests, osteo means the subchondral bone and chondral means the articular surface. This most commonly this involves the knee, and in the knee it's the most common. This is the lateral femoral condyle, this is the medial condyle. Most commonly the area in the knee is actually over the lateral aspect of the medial femoral condyle. This is the most commonly area involved in the osteochondral injury, but it could involve the elbow as well. In the elbow it's all may involve the capitulum of the humerus. It can involve the ankle as well, that is where it involves the talus as well. What is the theory behind it? According to some its authors, it is mostly secondary to trauma. According to some authors, this is actually secondary to degeneration of the articular cartilage. According to others, actually what happens is there is an atraumatic avascular necrosis of the subchondral bone due to some unknown reason, and once the subchondral bone collapses, the articular cartilage overlying it actually sinks in, leading to disruption of the articular cartilage surface and eventually leading to denuded subchondral bone and eventually leading to pain and arthritis of the joint. Usually the symptoms may include pain with walking as well, decreased range of motion, especially there may be associated, as in the knee it's mostly involving the medial femoral condyle, so there may be some tenderness on the palpation on the medial femoral condyle as well. And what is important to know is that you can get an x-ray. On x-ray, sometimes when you get an x-ray you get this kind of a picture, although your suspicion, but this could be maybe a lesion, this may not be a lesion as well. So sometimes you have to go for an MRI. And MRI is diagnostic because if you appreciate it over here, you can appreciate this definitely cartilaginous erosion as well as subchondral bone loss or collapse of the subchondral bone, which can be appreciated, and as well as edema, which is actually the medial femoral condyle. So what is the treatment if you see a lesion? Now this lesion could be a very small lesion as well. There could be simply disruption of the cartilage and with very less collapse, or it could be complete cartilaginous disruption with collapse of the bone and a very large lesion as well. So there are multiple options. One option is actually called as using an arthroscopic technique, that is going for subcutaneous drilling and use of K-wires. What happens is, if this is the lesion, arthroscopically the doctor drills it into the medullary cavity of the femoral canal, because in medullary cavity of the femoral canal there are pluripotent hematogenic cells which can come right across it, and this, although this cannot form the hyaline cartilage which is usually present over here, but a fibrocartilaginous cover can be formed, and therefore the derangement and those effects such as degenerative arthritis can be prevented, and then we can pass K-wires so that the subchondral bone collapse can be prevented. Other option is to actually pass screws as well, but if its segment is more than 2 by 2 centimeter or 4 centimeter square is a very large segment, then that may require a cartilaginous patch repair, are called as mosaicoplasty, because if it's a large site, even if we restore the bone, not all the area will be forming the fibrocartilage, and some part of the articular surface of the bone will be denuded and will lead to eventually osteoarthritis. Other option is actually, if it's involving a large bony piece, you take a graft right from there and patch it up on this surface so that the bony anatomy and bony surfaces can be restored. One way of classifying this is a classical lesion is actually involving the lateral surface of the medial femoral condyle, but other lesions may exist, such as extended classical, in which it involves the articular surface of the medial femoral condyle. This could be interocentral, which is involving the article surface mainly on the medial femoral condyle. It could be inferocentral, in which actually does not involve the medial femoral condyle but the lateral femoral condyle. Or it could be anteriorly as well, where just below or at that level of the cartilage collapses and leading to subchondral bone erosion and collapse. So this is another way you can appreciate it over. There's a lesion in the medial as well as the lateral femoral condyle involving both areas. So arthroscopically we can go for subcutaneous drilling, and as well as so that the what happens is the hematogenous pluripotent stem cells which are present in the bone marrow can come right from the medullary cavity into this area and form a fibrocartilage over these areas. And eventually you can appreciate after some treatment over the period of time, it is actually mostly the lateral femoral condyle has healed. It's almost in the healing phase as well. This is a diagram which is showing if it's a very large piece, it may require a bony fixation as well, because some bone graft needs to be placed over there, because that large area with the subchondral bone collapse, even if we cover that with the cartilage on the top, it will not stay there because there is no actually bone underneath that cartilage to support it. So if in that case you need to do the bone grafting with, and nowadays there is a headless screws as well which have actually invented, because the head may actually protrude into the intercartilaginous interarticular side. Therefore there is always a chance of some form of osteoarthritis later on which may develop by the patient. So now there's a new technique in which the headless screws are being utilized. The screws are inserted right into the bone, and eventually the bone cartilage covers it, and there is no intraarticular protrusion of the head of the screw. Sometimes if it's a large piece, 2 screws may be required as well. Sometimes a bony graft is used, when 1 screw may be enough. This is another diagram showing a large piece with which the bony grafting has been done, and then it's been covered with the 2 screws. Now coming to the knee injuries in children. Why it is important? Because as you know, the limb length inequality can be very much pronounced, especially in the case of children, because it's almost 9 mm to 10 mm of growth occurs every year at the distal femoral physis, and almost 5 to 6 mm of growth occurs at the proximal tibial physis. So if there is an injury to the knee, or there is injury to distal femoral and the proximal tibial physis, this means almost over 1 year time, almost 1.5 centimeter of limb length inequality will develop. And if a child suffers that injury, let's say suppose at 8 or 10 years of age, and has at least 4 or 5 years of growth remaining, that would practically mean when that child is 13 or 14-year-old, if it's a boy, that would mean almost having a 6 to 7 centimeter of limb length inequality. And just imagine how much problematic that would eventually become. A child is 13, 14-year-old and one limb is actually, let's say, 6 or 7 centimeters short. So that is why the knee injuries in children are, although they're very less, but highly problematic. Because why? Because eventually the limb length inequality is what develops during the knee injuries. So whenever a child complains of knee pain, we must get x-rays, we must get a detailed history, clinical examination, and physeal injuries and physis should be ruled out, because these injuries later on can lead to limb length inequality. Now coming to proximal tibial epiphyseal injuries. Again, a very rare phenomena, but as the physis in children is open, they can suffer from epiphyseal or physeal injuries, especially in the case of children. There is a Salter's classification for the proximal tibial epiphyseal. As you know, type 1 is when the physeal fracture is through and through the substance of the physis. Type 2 is when there is actually the fracture is extending into the metaphysis of the tibia. Type 3 is that the fracture is involving the substance as well as in extending into the epiphysis of the tibia. And type 4 is in which there is actually through and through, there is involving the physis, involving the epiphysis as well as the metaphysis. This is actually equivalent to the Salter's classification of from type 1 to type 4 injuries. how to manage those type 4 injuries. Now this is an x-ray which is showing a type 3 injury in which there was actually fracture involving the physes that are going into the epiphyses. The first and the foremost is that you need to deal with these injuries by either close reduction internal fixation under the fluoroscope guidance, or if there is no fluoroscope or you cannot closely reduce it, it may require open reduction internal fixation as well. What is important is that you need to make it sure that there is no articular step and there is no physeal disrupted or physeal malalignment, which is most important. For example, if this would have been a type 4 injury, which would have involved metaphyses, physes as well as epiphyses, so then you pass 1 or 2 screws into the epiphyses as well as 1 or 2 screws into the metaphyses. What is important in these children is not to pass a screw or even a cannulated K-wire through these physes, because passing that cannulated K-wire or screw through this physes would actually further damage the physes. So we need to protect the physes in children. Why? Because if this physis is not protected, this may get damaged. If it's damaged on this lateral side, for example, there would be one problem would be of limb length inequality. Other problem is that medial physis would outgrow the lateral physis, leading to this kind of a valgus deformity. So both important things have to be kept in mind, that we don't want a child becoming 13 or 14 to have a shorter limb, as well as we don't want a child to have a post-traumatic 1 to 2 years after the trauma to have either a varus or valgus deformity as well. So the management of these proximal tibial epiphyseal injuries has utmost importance. Now coming to the proximal tibial metaphyseal injuries, they are also very rare as compared to these epiphyseal injuries, but the problem over here is usually this does not involve the physis. As you can appreciate, the physis is lying over here, and this is actually extra articular or in the metaphyseal region mostly. But as compared to the alignment, one thing is more important. There's a phenomena called as Cosen's phenomena. Although the exact pathophysiology is not clear, but especially if you see this. Now this is an oblique fracture of the proximal tibial metaphysis, which has been restored very well in the cast, and as you can appreciate, there's a shed of the cast as well. This is probably an limb length casting, a closed reduction and casting has been done involving the knee as well as the ankle joint, and probably a good alignment has also been achieved. But this, despite all this, when the fracture heals, the cast is removed, physiotherapy started for the knee and the ankle. What it happens is later on there is always a valgus deformity of the knee. Probably the exact pathophysiology, the mechanism is not clear, but this is despite close reduction, adequate fixation or adequate reduction as well as adequate alignment. There is always tendency of these fractures to later on to develop a valgus deformity of the knee, which may be very problematic for the child as well, because eventually that will create a kind of a malalignment of the knee as well. There's a different classifications, which is this is involving the epiphysis area. It could be 1A or 2A, or it could be 3 as well, in which the whole of the epiphysis is actually going out along with the metaphyseal fractures. Or it could be 1B, involving in which is epiphyseal fracture as well, and there is chip of epiphysis which is going out as well. It could be 2B or 3B fractures. Now coming to the tibial tuberosity injuries, what is important over here is that if you can appreciate the tibial, this is a physis involving some part of epiphysis as well, and there is actually tibial tuberosity avulsion of fracture as well, which can be appreciated right over here. In children, what is important is that you have to be very careful with the physeal and epiphyseal injuries, because these are areas of growth, and later on there could be problems with the malalignment. There could be problems with the limb length inequality as well, especially if there is actually a disruption of the patella tendon from its tibial tuberosity. What is important to know is whether it is disrupted with a bony piece or is an isolated disruption as well, because when you're restoring it back in terms of, you may need a surgery actually. And if you see the anatomy, this is how the quadriceps tendon is coming in, is attaching on the superior and both the lateral surfaces, further augmented by medial lateral retinaculum and medial oblique ligaments. Then it forms the patellar ligament and attaches on the tibial tuberosity. Now, one way of disruption could be that it may be disrupted right from its where it is actually attaching. It is on a ligamentous disruption. This is more disastrous because then ligament to bone union is actually not very good. But in children, it's not mostly the case. It's always associated with the bony avulsion, that some bony piece is actually avulsed along with the patellar ligament, although it's more usually associated with high energy trauma. But the good part is the bone to bone union is always very good. And if you attach this bony piece back with some screws taking care of the physeals, this would mean that later on the patellar alignment can be restored. Then we may need medial retinaculum may be tightened as well. Why? Because we don't want later on the rupture medial retinaculum resulting in a lateral patellar subluxation or dislocation as well. Lateral needs to be tightened as well so that the patellar alignment remains same, and there may be decreased patellofemoral arthritis as well. Then coming to the patellar sleeve fractures. These are very rare fractures in children, but the important point is to note is that this patella starts ossifying at 4 to 5 years of age, and this is where the real cartilaginous part is. And sometimes what happens is that actually the disruption occurs at this cartilaginous part. On X-ray, the whole patella may look very much normal, but if you observe it closely, there may be a slight shadow of X-ray on the inferiorly. But usually, only thing which is more appreciable on the X-ray is actually the high riding patella, called as patella alta. That actually, instead of being over here, it has gone way upward, and you can appreciate it. Probably it's quite high riding patella on the X-ray. Then children maybe have a history of anterior knee pain. There may be trauma to anteriorly as well. Usually, the mechanism of injury is such that knee was flexed at the time of injury. With a sudden quadricep contraction, this resulted in a patellar sleeve fracture. When you examine the knee, there will be loss of knee extension because the quadricep mechanism would be lost, and patient would be unable to lift the knee in with a straight leg. This is actually indicative of that there may be a patellar sleeve fracture, there may be a patellar ligament rupture, or there could be a quadricep ligament rupture as well. Now you need to assess every possibility as per examination, and by then getting X-rays and MRI may also be required as well. If you see the X-rays, this is the kind of an X-ray you see in lateral view. You can appreciate this very high riding patella. Although because the patellar sleeve is mainly cartilaginous, it's not visible very well on X-rays. But if you see more closely, you can appreciate there is a very large shadow of something which is slightly bony and slightly cartilaginous and slightly lytic, which can be seen as well. There is definitely a lot of edema over here as well, which can be appreciated due to soft tissue swelling. So whenever you have history of such that there is a knee is flexed, there was sudden contraction of the quadriceps, and after that the patient was unable to extend his knee, there is high possibility that this may be a child may be having a patellar sleeve fracture. And when you get this kind of an X-ray with high riding patella, there may be shadowing, and maybe patella alta is seen as well, along with the soft tissue swelling, loss of extension. You must go for an MRI to check for whether this may be associated patellar sleeve fractures or not. What is important is to know is that these usually require, why we need to confirm it with an MRI, because if it is associated with patellar sleeve fractures, this needs repair, and repair in form of open adduction, internal fixation, and a tension band wiring construct is actually being done. When you open it up and the knee, and then you can realize this was a large chunk, a large fragment which was cartilaginous, not visible on X-ray but was very well visible on your eyes. Then that has to be restored back with the patella. ORIF with 2 K-wires and cerclage tension band wiring has to be done so that the knee extension mechanism is actually restored. The treatment is same for the patellar fractures actually, but it's like a patellar sleeve fracture, or it's patellar fracture, and patellar sleeve fracture is almost similar, but the important point is that the cartilaginous integrity to the patella has to be restored so that the extensor mechanism can be restored back. And this is the lateral view. You can appreciate it over here. If you see this patella and this patella, can you appreciate how much distance it has from the tibia, and how much distance this has from the tibia? Now it is actually restored back into its normal shape. Otherwise, this patella was very high riding patella because there was patellar sleeve was right here with the loss of patellar tendon, and the other half of the patella was riding up because there was a pull from the quadricep tendon. So actually the quadricep tendon was pulling from here, and the patellar tendon was pulling down this part of the patella, which was a cartilaginous part. So that has actually become high riding, and there is a lot of gap in between. But now you cannot appreciate any soft tissue shadowing, which was probably present right over here on this X-ray. In this section, we have briefly covered some of the injuries which may be related to the knee, multiple injuries related to the knee in children as well as into the adults. In this section, we have covered mainly the adult injuries, which mostly include the medial and lateral meniscus injuries and osteochondritis dissecans. In medial and lateral meniscus, why they are important is because the most importantly they have certain role in our knee. They are like when we are jumping or running, they are kind of shock absorbers. They also cause even distribution of weight and forces along the knee, so that the one part of the knee does not get degenerated or develops osteoarthritis. Then there are certain injuries around the knee which can occur in the children, which is very important to know, because what happens is because the most of the growth, almost 9 mm to 10 mm at the distal femoral physis and 5 to 6 mm occurs at the tibial proximal tibial physis. So if these growth centers are disturbed, this can lead to in 2, 3 year or 4 years time, this may lead up to 5 to 6 centimeters of inequality. Plus, if only one side of the physis is disrupted, this can lead to valgus or varus. It's varus or valgus problems, and eventually leading to malalignment of the knee. So these the injuries around the knee has to be very importantly checked. X-rays needs to be done. Physis needs to be carefully looked at, and then we can classify those injuries according to Salter-Harris classification. And once we have made the Salter-Harris classification, then we can go for either close reduction and casting, or close reduction with screws can be passed under the fluoroscope guidance, or if it's not, then open reduction internal fixation with the screws and K-wires can always be done as well. But what's important in children is to spare the physis, to protect the physis as much as possible. Thank you very much. Thanks for watching. Keep watching sqadia.com.